Hello, this is Dr. Gary Siskin, and today I'm going to begin a series of lectures on the role of embolization in trauma. And this first lecture focuses on splenic trauma. The most common mechanism of injury for splenic trauma is blunt abdominal injury. The spleen is actually the most injured organ in blunt abdominal trauma, and it occurs in almost 40,000 patients in the United States per year. It's most frequently caused by motor vehicle accidents, falls from heights, domestic violence, and sports-related trauma. Other causes include left-sided chest trauma with associated lower rib fractures, penetrating trauma, blast injuries, and iatrogenic trauma either after surgery or endoscopy. Whenever we evaluate a trauma patient, we want to grade their injury, and we use the AAST injury scoring scales because they are the most widely accepted and used system of classifying traumatic injuries, and 32 injury scores are currently available. The injury grade reflects severity, guides management, and aids in prognosis. And understanding these scales are important for speaking the same language as other physicians caring for trauma patients. This is the grading system for splenic trauma, and I don't want to go over it in too much detail, but we are looking at the extent of the subcapsular hematoma, the depth of the parenchymal laceration, and any intraparenchymal hematoma. Those are roughly the three major factors that we use to select a grade of injury. This was recently updated in 2018 and divided the levels of injury into parenchymal and structural injuries and vascular injuries. CT is usually the first-line imaging study in the setting of trauma. It has a lot of value. It helps determine the grade of splenic injury. It quantifies the volume of hemoperitoneum. It may reveal vascular abnormalities such as contrast blush or extravasation, pseudoaneurysms, or AV fistula. It may also detect other abnormalities in other organs that may warrant a laparotomy, and it certainly can serve as a baseline study for follow-up imaging. I included some examples here of splenic trauma, and I'm not going to go through them, but they're here if you want to look more closely at them. So this is an example of a grade 2 laceration. Here's an example of a grade 3 laceration with a more extensive subcapsular hematoma and a deeper laceration. Here's an example of a grade 4 laceration with some devascularization of parenchyma. And here's a grade 5 or a shattered spleen. When you're dealing with a primary rupture of the spleen, we do worry that the acute injury can lead to hemoperitoneum and hemorrhagic shock. And these are the patients who should be treated urgently with splenectomy. It's also important to be knowledgeable about the possibility of secondary or delayed rupture. This can occur in 2 to 8% of patients with splenic trauma treated with non-operative management, and up to 90% of delayed splenic rupture occurs within 2 weeks of injury. Delayed rupture may be due to subcapsular hematoma, pseudoaneurysm formation, splenic pseudocyst formation, or abscess formation which was present or developed after the initial trauma. It may also be due to a failure to recognize splenic injury on the initial CT, and this could be due to technical issues such as timing of injection, artifacts, or other issues. As a result of this possibility, follow-up surveillance CT may have a role in reducing the incidence of delayed rupture, since it can detect these vascularities in many patients. And frankly, it should be considered routine in patients with splenic injuries of grade 2 and higher. The patients who are at risk for delayed rupture are exactly the ones who can potentially benefit from splenic embolization. And embolization likely has a role in reducing the incidence of delayed splenic rupture. Treatment selection is initially based on the hemodynamic stability of the patient. A hemodynamically unstable patient is one with a systolic blood pressure less than 90, with evidence of skin vasoconstriction, altered level of consciousness, and or shortness of breath. Unstable patients can have a higher systolic blood pressure if they require large bolus infusions or have significant transfusion requirements. Generally speaking, hemodynamically unstable patients with severe splenic trauma should undergo splenectomy, especially if they require surgery to manage other injuries. But recognize that if a hospital has a lot of embolization experience, surgery may or may not be the first choice of treatment for these patients. At issue is the fact that splenectomy in the setting of severe trauma has a significant mortality rate and a high post-operative infection rate. And these issues have prompted a trend towards non-operative management for hemodynamically stable patients who have no other abdominal injuries. Not only do we want to avoid the potential complications of splenectomy, but there is a school of thought that the functions of the spleen may actually be valuable to most patients. And this includes filtering blood, recycling iron from mature red blood cells, and being involved in the immune recognition and processing and for pathogen elimination. And these factors have all led the charge towards non-operative management for patients experiencing splenic trauma. This is defined as bed rest and close monitoring with or without splenic embolization. And embolization has been an important addition to non-operative management. The failure rate of non-operative management decreases from 40% all the way down to 2 to 10% when embolization is performed. There are several prognostic factors for failure of non-operative management. This includes the splenic injury grade, the presence of significant hemoperitoneum, contrast extravasation at the time of admission, a high injury severity score, and other factors such as a lower systolic blood pressure at admission, transfusion of packed red blood cells, and an age greater than 40 years. Let's focus first on the grade of splenic injury. We know that the risk of failure for a grade 1 injury is less than 5%, but for a grade 5 injury, it could be as high as 75%, with a gradual increase as the grade increases. And that's one reason why it's so important to grade these appropriately on the initial CT scan that's performed. The presence of significant hemoperitoneum is also important. Moderate to large volume hemoperitoneum is associated with a roughly 10% failure rate with non-operative management. We're also looking for contrast extravasation on that initial CT, and this refers to early contrast enhancement in or outside of the splenic parenchyma, because these findings may lead to increased risk in association with non-operative management. And an injury severity score greater than 25 is a poor prognostic factor as well. The injury severity score is a multi-step process. The first thing that you're doing is looking at the patient's injury and giving it a score from 1 to 6. This is known as an abbreviated injury scale. It's meant to represent the threat to life associated with an injury. Once that's done for each injury that the patient has, the injury severity score can be calculated. Each injury is assigned an abbreviated injury scale score and is allocated to one of 6 body regions: head and neck, face, chest, abdomen, extremity, and external. And the 3 most severely injured body regions have their scores squared and added together. And an injury severity score greater than 25 is associated with a failure of non-operative management in splenic trauma. So remember, embolization enhances non-operative management of splenic trauma and reduces the risk of delayed splenic rupture. From a technical perspective, we always ask where exactly within the splenic arterial vasculature should embolization be performed. The first clue to this is really one of the first papers that was published on splenic trauma and the role of embolization, and this was by Sal Sclafani in the early 1990s. This paper concluded that patients without extravasation on angiography can successfully be managed with bed rest alone. But if extravasation on angiography is seen, then patients should undergo proximal splenic embolization, which can enhance non-operative management. In this paper, proximal embolization was performed with coils in between the dorsal pancreatic artery and the pancreatica magna. The goal of proximal splenic embolization is to maintain splenic perfusion at a lower pressure, allowing for spontaneous thrombosis of injured vessels. This doesn't directly stop bleeding, but instead enables clot formation by decreasing distal flow into the parenchyma. And because of the decreased parenchymal flow, proximal embolization can address the patient with multifocal injuries within the spleen. And it does this while preserving splenic immune function and preventing infarction and abscess formation. As I mentioned, the occlusion should be created between the dorsal pancreatic artery and the pancreatica magna in order to reduce the risk of pancreatic ischemia. In terms of embolic agent selection, coils may be advantageous in a very tortuous splenic artery since they can be delivered with a microcatheter. Some difficulty may be encountered with coil embolization due to the high flow nature and size of this vessel. In that case, plugs may be advantageous, but only if the necessary delivery catheter can make it into the splenic artery. They can be deployed quickly with less risk for migration, especially in a high flow vessel. Remember that we are trying to preserve splenic perfusion, and this can be done through several collateral pathways. There's the left gastric artery to the short gastric arteries within the gastrosplenic ligament, and then these can reperfuse the spleen. There's the dorsal pancreatic to the pancreatica magna via the transverse pancreatic artery. And then the spleen can also receive collateral blood via the gastroduodenal artery to the gastroepiploic artery, which then makes its way to the distal splenic artery. These are all possible collateral pathways when a proximal splenic artery embolization is performed. And here's one example of a procedure where there was a proximal embolization performed, and you can very clearly see both the gastric collateral pathways as well as the pancreatic collateral pathways reperfusing the distal splenic artery. There are advantages to proximal splenic embolization. This procedure has a shorter procedure time than distal embolization, which decreases the chance of patients becoming unstable in the IR suite and reduces radiation exposure in these patients. However, distal embolization does have a role in the treatment of splenic injury. In this particular case, the occlusion site is in the parenchymal vessels of the spleen where active bleeding or significant arterial injury is seen. This may or may not always be possible given the multifocal nature of blunt splenic injury and the tortuosity of the splenic artery. But if you can make it all the way to the bleeding site, then coils, particles, and liquids can and have been used successfully. Here's one example of extravasation from a distal splenic artery branch, which was treated successfully with multiple coils. And here's a second example. It does look similar, but it's a different case where there was extravasation from an upper pole branch, and we were able to navigate the tortuosity of the splenic artery in order to deploy coils all the way in the branch that was bleeding. We like to actually use combined proximal and distal embolization. In this approach, which we use in high-grade injuries with a defined distal arterial abnormality and angiography, we embolize both distally and proximally, and we do the proximal embolization before completing the procedure in order to lower perfusion pressure and promote healing. Here's an example in a patient with obvious multifocal injury of the spleen. In this particular case, we navigated out and embolized first this vessel and then a second vessel. And then once those two distal vessels were embolized, we left some coils proximally to decrease perfusion. Our approach has been determined largely by the presence or absence of active bleeding on angiography. If there's no active bleeding, then proximal embolization is performed. If there is active bleeding, we perform, or at least attempt to perform, a distal embolization followed by proximal embolization as the catheter is withdrawn. I did want to include for your reference the UPMC protocol, so it's here if you guys want to look at it. One other note is that splenic embolization is generally not performed in children, based on one study which showed no differences in the need for splenectomy, transfusion, or length of stay between embolization and true non-operative management. When looking at the outcomes of splenic embolization, it's important to remember that our goal is to avoid splenectomy and preserve the spleen. And it's known that patients with grade 4 or 5 injuries have significantly lower failure rates when treated with embolization compared to those treated with non-operative management alone. In addition, there's been no difference shown in the splenic salvage rate between proximal and distal embolization. I also think it's important to know that centers performing a high volume of angio and embolization tend to have lower splenectomy rates compared with centers that perform this procedure less frequently. The complication rates and mortality rates after surgery are known to be about 50% of a complication rate and a little more than 25% of mortality rate. After embolization, this is greatly decreased to a 5% complication rate and a 2.5% mortality rate. However, the complication rate may be slightly increased when using a combined approach, meaning proximal and distal, compared to either one alone. And these complications include splenic infarction, abscess formation, cyst formation, and coil migration. Splenic infarction is considered in a patient with severe left upper quadrant pain and tenderness, fever, leukocytosis, nausea and/or vomiting, and an elevated LDH. And patients with a post-embolization abscess may present with persistent fever, a left-sided pleural effusion, and left upper quadrant pain. It seems intuitive that there may be more complications with distal embolizations compared to proximal embolizations because there's no potential for collateral flow to preserve some perfusion. Early studies showed no significant difference except for a higher rate of splenic infarcts with distal embolization. A more recent meta-analysis showed that proximal embolization has less life-threatening complications, including rebleeding, infarction, abscess formation, and contrast nephropathy than distal embolization and a combined approach. A commonly asked question is whether or not certain vaccines are needed after a splenic embolization. We do know, based on CDC recommendations, that asplenic patients need a host of different vaccinations, which are outlined in this chart. However, most studies show that splenic function is preserved after embolization. There's been a few papers that have looked specifically at that. In one paper, the absence of Howell-Jolly bodies confirms that phagocytosis is preserved. These bodies are abnormal basophilic nuclear remnants within red blood cells due to deficient phagocytosis and would be indicative of reduced function if they were present, but in this study they were absent. In addition, OPSIs, or overwhelming post-splenectomy infections, have not been reported in the literature after splenic embolization. Since most studies show that splenic function is preserved after embolization, patients who undergo embolization are generally not routinely vaccinated in any special way. After treatment, most support a 1 to 3 day period of monitored observation, followed by a 1 to 3 day period of observation on a general ward. This is reasonable since most failures occur within the first 4 days. And once discharged, patients with a sedentary lifestyle can return to normal activity based on their original grade of injury. If there was a grade 1 to 2 injury, they would recover for less than 4 weeks, 4 to 8 weeks for grade 3 injuries, and greater than 8 weeks for grades 4 to 5. If they have a more active lifestyle, you want to give them more time to recover, which would be 4 to 8 weeks for grades 1 and 2 lacerations, greater than 8 weeks for grade 3 lacerations, and only after healing is demonstrated on imaging for grades 4 to 5 lacerations. And generally, 3 months is recommended before a return to contact sports. So in conclusion, the trend towards non-operative management of splenic trauma has resulted in high splenic salvage rates and lower morbidity. Splenic artery embolization has been an important part of this non-operative strategy and has transformed the management of hemodynamically stable patients with blunt splenic trauma.